Perfect Strangers, and they're triplets. They're actually triplets that were separated at birth. Anybody seen it? They were separated. They were separated at birth, and they found each other later in life. Interesting for you though, because it talks about research. They were part of a research study that was very unethical. They took, I don't want to spoiler alert, but these researchers took these 3 kids that were adopted out and put them with a low income family, a middle income family, and an upper class family. And they studied them, which is very unethical. They didn't know they were being studied. Long story short, they found each other, but they're so much alike physically, emotionally, gestures. If you get a chance to watch it, I think you'll find it fascinating. But yes, absolutely, that chemistry, that genetic load, it can totally change 2 different people. And those twin studies are a big part of what we look at in mental health. All right, so go ahead.
What's it called again?
3 Perfect Strangers.
3 Perfect Strangers. Oh, that's on the list, isn't it?
It's on the list. Yeah, I can't remember what streaming thing it's on, but very good.
Could that be like nature versus nurture too and stuff?
So absolutely, what we go through, we all got the same gene. Well, Melissa and I had the same genes because we're identical twins, but we may experience things we went through differently. The experiences we may have are interpreted differently because we're 2 different people, right? Why does somebody who has trauma after trauma in their life and they're still standing? We see that all the time. They're still standing, they're healthy. And then there's some people that go through a situation and they just fall apart. There's no right or wrong to that. It's just how people, it's that environmental, it's the nurture, it's how we interpret things. The one that fascinates me, and I just read a book about it this week. How does a family, like a normal family, loving family, end up having a child that's a sociopath or a killer? What we call antisocial personality disorder. When supposedly there were no negative nurturing things that were going on, and they raised a killer. So that fascinates me. Got a great book about that. But yes, the chemicals. Your brain is huge organ in your body. Extremely powerful in those chemicals. So as I said yesterday, you could be doing everything right, taking your meds, exercising, eating, practicing coping skills, talking to your support people, and you still can become ill, which is the sadness of mental illness. That's the tough one. Okay.
So I have something. I watched that, what was it called? American Murder, The Family Next Door.
That's actually, Melissa, that's the book I just read. The woman who, tell me. Go ahead.
Well, I watched it because it was on your binge list, and I was like, okay, I'm going to do something on Tuesday for school. And I mean, I couldn't really analyze him. He's just a true sociopath, right? He just wanted to kill his family sorry for anybody who hasn't seen it. To get with the girlfriend, and that's it, because they didn't really talk about it. It was just the documentary of what he did.
Mm-hmm.
Okay.
Yeah. Okay. It was all about him.
Okay.
He had no emotion or remorse or any feelings for the family. It was, what do I need to do for me?
Okay. Alrighty.
Yeah. That's it. And how does that happen? Because Mom says she loving family, supportive, she was there the whole way. They had a great relationship.
Yeah, the parents were more upset than he was, at the end, you could tell his parents were devastated.
And she's still visiting him in prison. I'm not making a judgment
Who's
statement about that.
Who's she?
Mom.
Oh, mom. Oh, well, yeah. I mean, that's her son.
Yeah, yeah. But that's something she struggled with in this book. Do I let him
Oh.
go? Do I support him?
Well, now I have to read the book.
Yeah, you can have the book. I'll give it to you.
Okay.
Yeah, really powerful. How do you live with yourself that you gave birth to a killer? He killed, not to spoil it, but he killed his little sister. That was molesting her and killed his 4-year-old sister.
Wait, was that in the documentary?
I believe so.
What are you talking
I
about?
don't remember that. I watched that like over break.
We're
Maybe
talking
I
about
need to.
Chris Watts.
Oh. Okay.
The one that killed his
Yeah,
wife
The
and
one
then
that
the
killed
two little
his
girls.
All right,
wife and his
rewind.
kids.
Oh, and she's
Rewind.
pregnant too.
Plus, and I had one of these conversations yesterday. Rewind. Okay. The family I had is on your binge watching list. That is about a woman whose son killed their 4-year-old daughter. And it's her struggle with, he's a sociopath, antisocial. She was struggling with forgiving him and trying to love him as her son. But he had no remorse for what he did. That's the family I had. Okay, the family next door is about
Is on
Chris
your
Watts.
watching list as well.
Yeah. God, I'm losing my mind. Yeah, Chris Watts is definitely a sociopath. He's the dude that killed the 2 girls
His 2 girls and his
pregnant
pregnant wife.
and put them into the oil tanks, right?
Yes.
And then did news conferences to talk about bring them home and we miss you.
Yeah.
Yeah.
He had a girlfriend on the side. Like, he just wanted to get rid of the family to, like after he did that, he called the realtor and was going to like put the house up for sale. And he was like, okay, well, now they're gone. I can move on with my girlfriends.
Right.
And like,
Right.
didn't think anything of it.
But like you were saying, the grandparents of his parents are more upset about it than he was.
Oh yeah, like at the end of it, like you could see like, I mean, and it looked like they had a good relationship with her parents too, you know, and like both sets of parents were just distraught, and he was just standing there like, all right, this is what I'm doing.
Yeah.
All right, so he was a sociopath as well. Like,
Absolutely. Yeah, absolutely.
Okay. All right.
I'm sorry. You went down the rabbit hole of serial killers with me.
All right.
And there's another one. I don't mean to get off topic, but there's another case, the one in out west where the guy supposedly killed his wife, and he had visitation with the 2 boys. And when DCF social worker brought them over, he slammed the door in her face and then killed them and started the house on fire. You guys remember that one?
No.
I don't remember.
I think I saw
Not
that
recently.
I forget what it was called, but it's ringing a bell.
I think her name was Powell. Cox and Powell family. Yeah, but it was like, if I can't have my 2 sons, nobody's having them. He took them all out. And DCF is being sued for that they were negligent. How'd you like to be that
I think
worker?
I listened to a podcast on that.
Yeah.
I think I listened to a podcast on that.
Yeah, it's a crazy
There's a really good
world out
podcast
there.
called Crime Junkie that talks about that stuff.
Oh my gosh, that's
Okay.
my favorite podcast.
Is it?
I love the serial killer ones.
See,
crime.
I literally could listen to it all day.
I know.
and our love for this actually stimulates the stigma in our country. So I'm just as guilty as everybody else. You know, we just sit here and talk about it like it's awesome. And that's why people don't go for help. They're like, I am not going to be labeled as mentally ill.
I was gonna say another like mentally healthy person, like you were saying, is one that can like admit it and acknowledge it and like recognize. You know,
like the girl we saw in the video yesterday. She was
Yeah.
powerful. Yeah. And take control of it. Absolutely. And that's hard for people to do because of that stigma. So right, let's jump into chapter 2. I hate this chapter. So, buckle your seatbelts. Can everybody see the slide?
Not yet.
I can't.
Oh. No, let's fix that. Should be coming up. Okay, so as I said, chapter 2 is intense. The author puts a lot in this chapter. I would encourage you to be very intimate with this chapter. At least read it a couple times to really get to know it. So as I'm lecturing, you're going to feel like you're on a roller coaster. It's a lot of information, but the positive is we're going to revisit these things down the line. So when I talk today about antidepressants, you'll get a little brief look into what an antidepressant medication is. But then when we get to the chapter on depression, we'll revisit those things. But if you can memorize your meds, learn your meds in some way, be able to pick out what kind of medication is what, it will definitely help you as time goes on. And actually your ATI book, the last 3 or 4 chapters of your ATI book is actually all medication. The way that book lays it out, they kind of put it towards the back. So this weekend, when you have a minute, visit your ATI book and take a look at those last chapters and kind of start putting those categories in your brain. And again, if I'm going too fast, let me know because I do get going on this chapter. All right, again, brain, most powerful organ we have. The brain has the ability to make us forget things we've experienced if they're too painful. It will, if we're in a lot of physical pain, it will knock us out so we don't feel it. And the brain rebuilds itself. Even when there's damage to the brain, it can rebuild itself. It's always growing. A lot of techniques people are using to try to stimulate the brain, keep it going. But it's an organ we don't think about. I don't think we think about as often as our heart or our liver, but it runs everything. So take a trip back to biology when you're reading. Just kind of review the different parts of the brain. You won't have you won't have a lot of questions on the exam on the parts of the brain, but make sure you know the different areas. The part that we really specialize or focus in on in mental health is the limbic system. And whenever you see limbic, think emotion, anything connected with the control of emotion or the emotional state of somebody. And again, if I have a head injury in my limbic system, my emotions are going to probably be dysfunctional or out of control because of that injury. Cerebrum. We have 4 lobes in the cerebrum. Again, the frontal lobe, it was the one we very much focus on in mental health. It controls emotion and moral behavior. So if you have a head injury in the frontal lobe area, you may exhibit behaviors that you normally would not have before the injury. Stealing, hurting people, whatever it might be, sexual acting out. And your emotions could be very labile. So the word labile, you're going to see a lot, L-A-B-I-L-E, and that means up and down. I'm crying one minute, I'm laughing the next minute. Those are labile emotions. Okay, and then the cerebellum coordinates our movement, our ability to get our body where we want it to. And if there's damage in those areas, You might see paralysis. Some of our mental health medications affects this area. So we have some movement disorders that occur because of medication that we're going to talk about today. And the brain stem kind of pulls it all together. And I know you guys can remember having to memorize those cranial nerves. Just a quick look at that. There might be one question on our exam on the brain. Nothing too tricky. Okay, so again, we focus on the limbic system. That is our control for emotion, control for mental expression, mental health, energy, sleep, memory. All right, I'm not a brain expert, but any general questions on the brain or comments? Head injuries fascinate me, like the different areas that our veterans are getting head injuries and the behavior results. So there's a lot of studies going on about that. There's some experimental mental health interventions like electrical stimulation to the brain, parts of the brain, to see if it can affect mood, that we'll talk about in other chapters. So there's something interesting research things that are going on with how to alter the brain. All right, neurotransmitters. We all have neurotransmitters. These are little chemical messengers that jump between our synapses to tell our body what to do, to tell our body what to feel. When those neurotransmitters are out of whack, or there's a lack of them or too many of them, is when we get our mental health behaviors. So you will learn a couple neurotransmitters, and you will learn which mental health diagnosis they are connected to. And I have a great little video to show you that's going to help you remember. But neurotransmitters are powerful. And when people, I don't know if anybody saw my meme I posted last night. It was like, people tell you, when people say it's all mental health is all in your head. Yeah, where else would it be? It's in your head. Mental illness, addiction is a chemical. It is a chemical brain disease. It is not anything that anybody did. It's not a moral disease. And luckily with meds, it can be controlled. Remember, we didn't have meds till 1950. Really, in the scheme of things, that may be a long time ago for some of you, but in the scheme of things, that's not that long ago. So we've made huge leaps and bounds as far as trying to treat mental illness. Although there are some challenges to get that medicine into people, which we'll talk about. Okay, so those
I don't mean to interrupt, Dr.
Yes,
Green,
sir. Go ahead.
but I found that kind of fascinating last night when I was studying. Like 1950, when you think about it, like really was like not that long ago. And so the fact that like we didn't have like medication to help until then, like, was just mind blowing to me.
And the people that suffered.
Yeah.
The people that suffered all those years.
I know. I was like writing down the dates, and I was like, it just like kept clicking to. I was like, 1950. What? Like, it's just so close to now.
No, you're absolutely right. It really was yesterday, in the scheme of things, and what we did to people, the lobotomies and the
All right, sorry.
Insulin shock. Yeah, it is fascinating. And you could always interrupt. Please always interrupt. I'll never be insulted. Yeah, I was actually thinking the same thing. I was born in '63, and I was thinking, yes, God, not long ago. So what did women do in the '50s who were depressed when there wasn't an antidepressant? How many people suffered? Yeah.
Yeah, it's really sad.
Pretty well. But we're We're on it. We're on an upswing. Now we have so many medicines. Oh, we have
Right.
some challenges. We have challenges to get people to take them. We'll talk about those.
Can I share a quick story on that? After you came on around Halloween and did that, in Lynn's class, and you shared that Halloween presentation or whatever, I was talking to my grandma about it, and she said that her mom's sister, so her aunt, had basically postpartum depression when she had her first kid, but back then that's not a thing, and so she was telling me how they basically took her kid away and locked her up to the one of the asylums that you were talking about, and that's where she died and everything. No one ever saw her, how we were talking about how that's where people would put their families and
Yeah,
almost
isn't
lock
that
them
awful?
up. But
For
there's some-
postpartum depression that today is very treatable. Very,
yeah.
yeah. Even immigrants, like people came here and couldn't speak English, so they just locked them up. They end up spending their life in asylums because they couldn't communicate.
Yeah, and ironically, they were immigrants from Armenia.
That is so sad.
Yeah.
That is, it happened all the time. A husband could take his wife and drop her off if he was sick of her.
Well, he was the one that was pushing for it basically and took the kid after. But my grandma, and again, I was having the thing like Amber. I was just that wasn't even that long ago. That was when my grandma was in her 20s and she's still alive.
I don't know about your family, but families don't talk about it. It's kind of like hush hush.
Right.
There's that shame to it, where the woman did nothing wrong.
No.
What she was experiencing was absolutely normal. Oh.
But for the rest of her life and without her baby. So.
And abuse. There's a lot of abuse in those asylums. Yeah, I'm going to repost that psychotic PowerPoint I gave you in October if people want to look at it again. I love the history. But even genetic disorders, like if you were a genetic disorder where you're really big, then you have long limbs, and I think Lincoln had it. For somebody help me. Marson syndrome. I know you all just hit topics.
The giant one?
Yeah.
Something Megley or
Yeah. It's
Megaly.
okay. They would lock people like that up because they were weird. There was a family. There was a rich family in New York that locked their kid up because they were embarrassed by his life. And obviously mental retardation, developmental disability, Down syndrome. Yeah, so sad. We've come a long way, but we still got a way to go. You guys need to break that stigma. Talk about. Yeah, I mean, talk to your families. It's and families don't talk about it. We all got that crazy Uncle George in our family that nobody talks about. That somebody kept in their house and took care of them. Okay, I love the stories. Keep up the stories. Neurotransmitters can be excitatory or inhibitory. Excitatory or inhibitory. So they can accelerate somebody or they can depress or bring them down. Okay, so let's go through some of the common ones. Dopamine. So when you see dopamine, think schizophrenia. In schizophrenia, like our girl talked about yesterday, where she was seeing the clowns, feeling them touch her, there's too much dopamine within her system. There's too much dopamine. It's excitatory. The dopamine stimulating her senses to a degree where it's out of control, or it's what we call psychotic. Okay, so if I've got too much dopamine, the goal would be, if I'm going to create a medicine to help with schizophrenia, the goal would be to create a medicine that's going to decrease that dopamine within the system. Does that make sense? Okay, so do it dopamine. That's how you can remember it. Accelerated. Do it dopamine. Schizophrenia. Norepinephrine is a very important one of our neurotransmitters. It affects our sleep, our ability to be attentive. People with ADHD and ADD often have alterations in norepinephrine. Epinephrine is our fight or flight response. So when we are stressed or under attack, this comes back way from the cavemen, it's still with us. We have a fight or flight response that epinephrine accelerates us to protect ourselves. We either run from the situation or the danger, or we get ready to fight it. And then epinephrine is one they will use in codes. In med-surg codes, you will see that it excites the body. It gets things going. Glutamate is another one of our excitatory neurotransmitters. I don't know a lot about glutamate. Just that you have to be careful. You're taking like an over-the-counter supplement that you're not taking too much because it can become toxic. But the big one out of the excitatory that I really want you to know is that dopamine. Dopamine. Yeah. Questions on the excitatory?
Well, isn't the lack of dopamine linked to Parkinson's?
Yes. Yeah. Absolutely.
Okay.
Yeah. And so, not to really confuse you, but one of the side effects of antipsychotics are Parkinson-like symptoms from the medication. And we'll talk about that in a second. It's caused by the medication. Yep. Okay, inhibitory. So low, think low energy, slowing people down. Serotonin's our big one. We call it smiley serotonin. That is the neurotransmitter connected to depression. So if someone is depressed, they do not have enough serotonin in their system. It makes them tired. It makes them not apathetic, low sex drive, crying, low emotion, not eating. So if I'm going to create a med to help depression, what do I want to do to this? What do I want the serotonin to do?
Inhibit.
Increase.
Yeah, I want it to increase. Right. How do I get it to increase in the system?
The SSRIs.
Okay. Yep. So SSRI is our major category of antidepressants. It's called selective serotonin reuptake inhibitors. So those meds work great. They block transfer of the neurotransmitter so that the serotonin can't leave the neuron. We want more serotonin in the neuron. Does that make sense? Yes, no,
Yes.
maybe? Okay. So serotonin, depression, we have great meds that can help with that. GABA. GABA is connected to anxiety. You can actually buy GABA over the counter and take it. Some people do that as a supplement to treat anxiety versus a anti-anxiety medication. So if you see GABA, think anxiety. There's not enough GABA, so people get anxious. Acetylcholine can be either an excitatory or an inhibitory neurotransmitter, depending on where it is, the person. But acetylcholine is very much connected to our ability to sleep, that REM sleep, being able to wake in the morning. muscles, getting your muscles going to become alert. Okay, and histamine is also a neurotransmitter that I don't know a lot about, but obviously connected to things like allergic reactions. You would introduce histamine into the body to treat that. But that makes sense. It's a neuromodulator. Questions on that slide? Okay, let's take a look. Let's take a jump off and look at that video while we have. This video it's pretty simple. It's actually posted in your, it is posted in Canvas. You can watch it again. But I really like it. It's simple. It's a good way for students to remember those important neurotransmitters.
Our brains are amazing. They think about problems, tell body parts to move, tell the stomach how to digest, figure out what we see, taste, smell, and touch. They are the boss of the body. They tell everything else how to work. They even help us feel happy, excited, scared, mad, and sad. Like all body parts, the brain can sometimes have problems working correctly, and this can lead to mental illness. Sometimes brains make people feel worried too much of the time. This is called anxiety. Some brains make people feel too much sadness. This is called depression. Other brains make people feel like they need to repeat actions and that their work is never good enough. This is called OCD. Some brains make people feel very sad at times and overly happy and excited at other times. This is called bipolar. Some brains do not communicate the message to your body that it needs to focus and stay on task. This is called ADD or ADHD. And some brains make people think they hear, see, or touch things that aren't really there, or think things that aren't true. This is called schizophrenia. Why does the brain, the boss of the whole body, not work right sometimes? Doctors and scientists are still learning, but they know it often has to do with how the brain communicates. The brain is similar to a highly organized collection of wires. It receives all the signals that come into the eyes and ears and nose and sends on messages to the mouth and feet and hands. Neurons are like the brain's wires. They are the connectors that move messages along, and there are 100 billion of them at work in the brain all the time. But neurons must talk to other neurons to move messages along. And the way they talk to each other is through chemical messengers. These messengers, called neurotransmitters, cross the tiny gaps in between neurons, ferrying messages from one neuron to the next. When a neuron gets just the right neurotransmitter at just the right time, it helps the brain concentrate, relax, shift attention, and create. But when neurotransmitters aren't able to do their job right, when there are too many messengers or too few, the message is not understood correctly. The brain loses focus, gets tired, worries, or retreats from reality. For example, when neurons called smiley serotonin don't make it across the neuron gap, the brain makes the whole body feel sad and depressed. Doctors have found that if they give a depressed patient some medicine to help smiley serotonin, it helps the brain feel happier. Doctors have discovered many medicines that help correct neurotransmitter levels in the brain. These other medicines influence not only serotonin, but other brain messengers such as do-it-dopamine, gregarious GABA, and nerdy norepinephrine. Doctors are also learning that for some brains, eating a healthier diet, exercise, meditation, and enjoying happier relationships can be very helpful in getting neurotransmitter levels back to working order. Our brains work hard being in charge of our bodies. Most of the time, people do not even notice just how well their brains are working. But if pathways in the brain start working poorly, it can be confusing and scary for that person and his family and friends. It is very important that people whose brains need help work closely with their doctor to get the help they need. Doctors know many ways to help get the brain working properly again so that the brain can get back to being a great boss.
You know, and as our speaker said yesterday, remember when she was talking about going in the hospital overnight and it wasn't enough. She needed more intense supervision. It takes time to get that brain back to where it was. So it's not something that can happen overnight. And that's frustrating for people who have mental illnesses. We don't know what medication's going to work for somebody. So people often feel like guinea pigs. They kind of try a med, have to wean off that med, try another one. Very frustrating for people. Can you guys see the slide again?
No.
No.
Okay. Let me go backwards. I hope someday we can take somebody's blood and take a blood sample and say Prozac's going to work for you. So let's jump right into Prozac. But we don't have that right now. One of the things we have is family history. If it worked for a family member, it often works for you. Go ahead.
Professor Green, they actually do have a mouth swab. I don't know if you've heard of it or seen it. That they can do, especially for elders, that shows like which antidepressant will work best, and things like that, which is kind of cool.
It's fairly new, and I don't even know what it's called. But
I
they're
don't know
using
what I don't know what it's called either.
So, yeah. I mean, we're getting there. They're using it with kids. It'll tell which medications are more likely to work. So that's kind of cool.
Yeah.
A lot of insurances aren't covering it yet.
Yeah, insurance is always a pain.
As a technique. Yeah, we're getting there. I'll find out what it's called and post it. Yeah, for sure. They're using that on kids where I was working for a while. So they weren't experimenting with them. All right, let's see. I'm guessing you can see the slides, right? We talked about twin studies. We talked about genetics. There's a lot of theories. Again, we don't know where mental illness totally comes from. There's a lot of theories about immunology, that immune systems are very connected to mental illnesses. And I believe this actually, because if you look at things like lupus, multiple sclerosis, those are fibromyalgia, those are immunocompromised diseases that very much have an emotional component. People who are struggling from those have often changes in their emotions. A lot of research going on about that right now. And those are invisible They can be, I call them invisible diseases. So if you know someone with lupus or one of the other ones I mentioned, people can look like they're okay physically, but they're not. They're in pain, they're struggling emotionally. So those are, I don't know, I have a soft spot for those diseases because people look okay, people think they're faking it, and they really are not. There's a lot going on inside people's bodies. Another theory through the years has been some sort of virus that got to the fetus during development, during pregnancy. Again, if you're looking for a research top, interesting one. What happened in utero that possibly affected this child who has schizophrenia. But again, we don't know. It is definitely that nature nurture. I feel it's the nature nurture, the combination of our genes, what we've been through, what we put in our body, how we cope. And it's such a holistic view of who's ill and who's not. And we can be healthy today. We can be mentally healthy today and mentally ill tomorrow. Again, it's a very fine line. Okay, just to mention some brain imaging techniques, we do have CAT scans, MRIs, PET scans, things that we can look at the brain. It is mostly used in research, unfortunately, in mental health. And it's powerful. The research is powerful. There's a great picture in your book. I think it's a brain, I don't want to say a normal brain, but a brain without schizophrenia and a brain with schizophrenia. And there are definitely differences. It is very cool. The only time we will scan people when they come to the hospital with a CAT scan or an MRI is if we're worried about a brain tumor or a head injury, or something physical going on in the brain. Then insurances will cover it. You will not see people having MRIs or CAT scans routinely on admission to the mental health unit, unfortunately. Sometimes people have very sudden changes in behavior, and it is something physical. It's a brain tumor or it's something going on in their body. So we are mental health nurses, but we always have to rule out the physical first. Very interesting stuff for research. Okay, drugs. Let's talk about drugs. Our drugs are called psychotropic medication. Psychotropic meds are anything that changes the chemistry of the brain that will affect our mood or behavior. And there's different categories of psychopharmacology under that. As I said, we don't know what's going to work for people. So it often depends on what prescriber you just saw. They may have a certain medication they really like, something new came out they want to try. The SSRIs, the Prozac that have been around, they're very well tested. They work. But it just depends on what you're going to be prescribed. But they will ask, hopefully they'll ask, anybody in your family is mentally ill? Have they ever been on an antidepressant and did it help? Because you share that genetic load, and sometimes that'll work for people within the family. There are a lot of mental health medications that were actually made for something else. So their approved use was for seizures, but we use them to control mood. So I guess just as a red flag, when you're looking at your client's meds, kind of look at why they're taking it, because there's a lot of off-label use in mental health. If your client is on Depakote, which is a seizure medication, prevents seizures, don't assume they have a seizure disorder. That is also used for bipolar disorder. Does that make sense? A lot of off-label uses.
Is that like Seroquel?
Seroquel. Seroquel is yes. Tell me
No,
what you think.
doesn't that have like you can use it for like some people use it throughout the day, but then sometimes people can use it to like sleep or
Sleep.
like anxiety. But
Yeah.
also I heard it was for like schizophrenic. That can be kind of like as a maintenance.
Thought process. Yeah, it's used. That's a good example. That's used for a lot of different things in mental health. Yeah, absolutely. Yeah, I was even thinking broader, like, well, let me give you another example. Clonidine. You guys, clonidine is a blood pressure medicine, right? Lowers your blood pressure. Clonidine. They use that with kids with ADHD. For some reason, it helps kids with impulsivity. It's one of the effects. Great, it helps them, but we have to worry about their blood pressure dropping, right? Because what it does is actually drop their blood pressure.
Or gabapentin, is that a good example?
Yeah, gabapentin.
That's for like the neuropathy pain, and then the also for anxiety. I think people can use it for. Maybe not.
And bipolar, it stabilizes
Okay.
moods. Yep, absolutely. So yeah, just investigate a little why somebody's on it. Don't assume. Clonidine also helps kids not wet the bed at night, which is another thing they use it for. Just so always ask your patient what they're taking it for. So those off-label uses. Our mental health medications have what's called black box warnings. Unfortunately, there's a lot of negative side effects we're going to talk about. The biggest one is obviously suicide. And there has been cases where people started these medications and committed suicide. So the pharmaceutical companies have to put on a black box warning. One of the things we always watch out for when somebody starts a new medication in mental health is increased suicidal thoughts. So again, we have to try to, as a provider, we have to try to choose a med that's going to work for the person. How quickly is it going to work? Healthy is the person. Is that person 5 years old? Is that person 95 years old? How's their liver, kidney excreting? Do the larger kind of the rule mental health is they start low, prescribers start low doses and work their way up in case there's going to be a side effect of some sort. And mental health medication in general, people cannot stop it abruptly. So we always have to teach our patients, don't just stop your meds. What can happen is either withdrawal, very uncomfortable withdrawal, or a rebound effect of the symptom. So if I'm on an antidepressant and I just stop it, as that leaves my system, I can have a rebound effect of a very severe depression. It just comes back very quick. We always teach, don't stop. We have to wean off. So that's what I was talking about, that guinea pig. If I start Prozac and it didn't work, now I've got to wean off that Prozac probably over a month and then restart another medication and build it back up over a month. So you're talking about being depressed and suicidal for, for 8 weeks, which is very hard on people. It's not an easy take a pill and it's better, of course. Our biggest challenge in mental health is getting people to take their medication. The majority of illnesses that we're going to study, people don't think they're ill, particularly schizophrenia. Why should I take a pill if there's nothing wrong with me? The other unfortunate thing is these medications for schizophrenia, which are called antipsychotics, have a lot of severe side effects. So you're going to give me a medicine that's going to make me drool, can't sit still, I'm impotent, I'm tired, I can't stay awake. I could have a reaction that could cause death. And you want me to take this every day when there's nothing wrong with it. And you can understand where people are coming from in their thought process. And then we have, not to get ahead, but then we have medications that help with those side effects. So you're giving me this med that's making me do all these things. I could die from this med. There's nothing wrong with me. And now you want me to take another medicine that's going to help with the side effects? You guys are crazy. But you can see the thought process. And what happens is, remember we talked about that revolving door of the hospital. And it's very true. What happens is people are Baker acted, they get in the hospital, they get on their meds, they're stabilized, they're discharged home, and they stop their meds. It's called a kindling effect in pharmacology. Every time you start and stop a medication, it takes a little longer for your body to recognize that med when you put it back in. It's kindling, like a kindling of wood. It just builds up. And sometimes with these meds, they just stop working. People wake up one day and it's not going to work anymore. People have to start over and find a new medicine. So a lot of frustrations with people. So when your patients are talking to you about this, it's true. I mean, it is true. Nobody wants to walk around drooling or not being able to communicate or stay awake. These drugs do work, but they do have a lot of side effects. Just be aware of that. Okay, we're going to start with antipsychotics. And psychotic means out of touch with reality. So anything that's an antipsychotic drug helps somebody bring their thoughts back to reality. Aren't seeing clowns, don't feel like the clowns are touching them. Even thoughts of suicide can be helped with antipsychotic drugs. And these are our tougher drugs as far as side effects. So if you see antipsychotic, think schizophrenia, but they are using them for some PTSD. People who have PTSD get their thoughts straightened out, depression, to kind of thoughts out. Okay, you're ready? Let's spin. There are three levels of antipsychotic: conventional, second generation, and third generation. So conventional antipsychotics are older medications. So we remember was talking the very first one that came around was Thorazine. 1950, the very first drug. These are older medications. They work on the symptoms of schizophrenia, but there are a lot of side effects with them. People still take them. They're used a lot for sedation. There are people that just like these. They've been on them for years and they like them. So those are conventional. The newer group that has come along in the last 20, 30 years is called second generation. Second generation antipsychotics have less side effects of the physical side effects. They also help people with energy and wanting to participate in life, kind of going to work, and they help with the energy part of schizophrenia. These are more expensive medications. The clozapine, risperidone, olanzapine are very common ones you will see. A little more expensive than the old ones, less side effects. The big problem with these drugs is they make people gain weight. Patients describe it as just wanting to eat everything, can't stop. So if I have schizophrenia and I take Zyprexa, it takes away my voices. I'm able to go to work, but I just put on 65 pounds. So emotionally, my self-esteem is down, could get depressed. Physically, my blood pressure's up, I'm developing diabetes. I mean, you guys can see the problem. And I've worked with doctors, one doctor in particular who really struggled with this. They're great drugs, they give people quality of life, but they're killing people 20 years earlier than people on the older drugs. So yeah, public health wise, we can teach people to exercise and eat right and all that jazz. But they are definitely affecting people's health. And we've just been using them 20, 30 years. We don't even know at the end of your career what they're going to be doing to people. Third generation is, there's always a third category of these. So the third doesn't fit into either of the other ones. Aripiprazole is an example of a third generation antipsychotic. It is a dopamine system stabilizer. The other name for it is Abilify. It is a drug that works with schizophrenia and depression, but it does make people gain the weight, that side effect. The thing I don't like about Abilify is they market it, the pharmaceutical company markets it as an antidepressant. And you may have seen the commercial. This is the commercial where the girl's walking and she's got like clouds over her. If you take Abilify, your depression will go away. Okay. But they're not telling people Abilify is actually an antipsychotic. It affects the thought process. It's going to possibly have you gain weight. I just don't like the way they advertise. But you will see, there's kids at 5 years old on Abilify. They're using it with children. I was actually, this will age myself, I was actually part of a study in Rochester, New York, where they tested this out before the med was approved. And what we were seeing back then was people gaining weight. They had to really watch their weight. Questions on those three categories?
No questions. I just have a quick story. So I used to work in a pharmacy in Arlington, and they partnered with the county to give Abilify to patients, and they would come in and get their shot because it was just easier. And I had a patient, a customer who came in, and like at the beginning, when it was time for his shot, he just dropped his pants in the middle of the store. And he was, you could tell that he had, I think he was diagnosed with schizophrenia on his paperwork. And by the end, like, he just looked different because he acted so different by the end of his treatment. And he was on Abilify.
Yeah, quality of life, absolutely. And what you're talking about is a decanoate shot. They work. So it's a shot that you have maybe once a month, and it's in your system. People, remember we talked about, I don't want to take that pill. This way, we don't have to do that every day. It's in their system, and it helps people. That shot you're talking about costs, you can correct me if you know, but I think it costs about $5,000, and the company will donate those. A lot of insurances are not even covering them.
Yeah, he was sponsored by the county or something like that.
Yeah. So expense-wise, a pill of Haldol is probably 2 cents to make. An injection of Abilify, probably $5,000. Yeah, if you're the insurance company, which one are you going to approve? You don't care about the side effects. Yeah, absolutely. He was there for a shot. He didn't care that he had pulling his pants down in the pharmacy. He was doing what he was told. That's that altered thinking. That those social skills aren't always there. Great story. Any other questions? Learn them. I can't put them into your head, so learn them. Flashcards, graphs, however you want to memorize those. Okay, again, they treat psychotic symptoms. They block the dopamine receptors so that there's not too much dopamine building up in people's systems. But we do got side effects. All right, we're gonna talk about one side effect, and then I promise I'm gonna give you a break, okay? Side effects from antipsychotic. We call them extrapyramidal symptoms. There's a spectrum of different symptoms people can have. One of the ones that is a urgent, we need to jump on this right away, it's a medical emergency, is called acute dystonia or dystonic reaction. So this happens when somebody is taking an antipsychotic. It can be their first dose, or it can be they've been on it for 2 years and it just happens to happen. It starts with people feeling like their throat is closing up, they're having trouble swallowing, their neck gets stiff, and it gets into a position where it's stuck, usually upward. Their eyes will roll back into their head. They can't control their eyes. Very uncomfortable. It needs to be dealt with immediately, and it is caused by the medication. This is an example of one of those where you're going to have a reaction, and now I'm going to offer you another med to take care of that.
Can I share something
Yeah.
about? I had a patient that I guess he took antipsychotics. It was prescribed, and it was way too strong for him. And he was sitting in the day area, and I was checking on him, and then I eventually realized he hasn't moved in like probably 10 minutes. Like he was just a stone. And so I guess it was like a reaction to the medication, and he couldn't move anything. You could like take his hand and like move it here, and he would keep it there. And so they had to like put an ECG on him to make sure his heart wasn't going to stop. And they gave him some kind of, I don't know what they gave him, but he came out of it. But it was really scary because we thought it was his heart was going to stop or something. So
good observations. Good thing you noticed it. Yeah, because they can't express it when they're stuck in that state.
Mm-hmm.
Good one. All right, let me show you what it looks like. I actually have a little video. This is a real video from an emergency room. It's also on your Canvas if you want to watch it again. It's one of my faves. But yeah, try to put yourself in this guy's shoes while you're watching it. Would you really go home and take your meds after this?
After you show it, I have a question because I actually watched it, but I have a question about the treatment they did.
Okay, go ahead.
How or why does the Benadryl work?
It's you know what, this is not my specialty, so I'm not the best person to ask, but it's something with the histamine. The histamine, I don't know. I don't know.
Well, yeah,
No,
but
it's fine. I was just like amazed by it because I was like,
It is.
well, if you're saying that it's basically like kind of like an anaphylaxis reaction, it sounds like.
The Benadryl works. I will find out for you because I should know. That's a good question. Let's watch this and we'll talk about it.
okay.
You guys got sound? I didn't think so.
No.
Of course not. Yeah, pharmacy's not my specialty, but I can look things up. I should know why it works though. All right, dude in the emergency room.
So, when did you start having trouble talking? Early this morning? And did you take any drugs? Other than your prescribed drugs?
Oh.
No? You don't do cocaine or anything like that? No? Okay. Count to 10 for me.
1, 2, 3, 4, 5, 6.
Okay, that's good.
Yeah. Wait.
I do. I feel better. I feel like I can talk.
We'll get it done later, level as well.
And say what I want to say now.
All right.
I feel better. I am glad they came to see you all. Hey, see you all here at LCD.
Quick question. Has the pupil on this eye, has it been bigger than the pupil on your other eye for a while?
Yeah. Yes, it has.
It has. Okay.
It has.
Okay. But has that ever been ever since you had your head injury?
Yeah.
Okay. You still want to spin the head?
Let's talk about it. Count to 10 for me now.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
All right.
1, 2, 3.
Now he's counting it up. Okay.
Yeah. I feel better. I feel better.
Now your voice isn't perfect, but is this how you normally talk?
No.
Not yet. Not yet. Yeah, but your speech is still a little slurred.
Yeah, because I had this take out of my.
Okay.
I don't feel better right now. But the doctor said, give me some Benadryl, and the doctor knew exactly what the purpose was. The purpose was to give me some Benadryl, and that's what they did for me. Give me some Benadryl.
Now, are you talking back to normal for you? Is this how you talk?
Yeah.
Okay, all right. So you had some traumatic brain injury sometime in the past, is that right?
They cut my brain.
Okay, and so, but you have some psychiatric issues too that you're being treated for.
I be having
flashbacks. Hey, so you have your right guard over there, and sometimes people actually huff that to get a high on it.
What?
Yeah, but were you using the right guard at all?
No.
No, you weren't.
I didn't use it for deodorant.
For deodorant, that's used like it's supposed to be good. Okay, well you're very kind to the rest of us, you know. That's thoughtful.
Very kind too, and I appreciate you for helping me.
All right, you're welcome. You're welcome.
I knew when I was speaking this morning, I knew it was something going on.
I love that guy. So that is a dystonic reaction. And Amber, I can't answer your question, but I am going to find an answer to that. So
No, it's okay.
No, I want to know now. Now I'm curious.
I think I know the answer.
It's magic.
That diphenhydramine has an anticholinergic effect, and it works on blocking the neurotransmitter acetylcholine, which is responsible for like involuntary muscle movement. So I think he's just like, you're having that constant acetylcholine like contraction neuromuscular effect or whatever. So it like blocks that.
Oh, you go, Alexis. Listen to her.
That makes sense. Thank you.
That makes sense. Okay. So, and Benadryl you can buy over the counter. You can keep it with you. So that's used pretty commonly. So some people will take Benadryl along with their medication every day, kind of as a standing med, so that that doesn't happen. The other common ones we use are Cogentin and Artane. And I'm guessing they kind of do the same thing. That anticholinergic, anti-Parkinsonian, like they help people get control of those movements. But again, if you're having that reaction, you're going to go home and take your meds right away. If you just spent the day in ED, you're doing what the doctor told you to do, right? I love that doctor. I'm assuming he was a doctor, could have been a nurse. Great assessment. He's looking at the head injury. He's looking at drug use. Huffing. This looked like maybe possibly a street person. He did a nice job with kind of doing that full assessment and connecting with the patient.
And then he was like, "Why are you slurring your words?" And I was like, "Well, he just got 50 milligrams of IV Benadryl." Yeah. I think anyone would slur their words.
But I think that dude had a little slur on a normal day. His head injury, where he started with. So he had some things he could tell us. He's had a life. Any questions or comments on the video? It does happen, and sometimes it comes out of nowhere. You may be sitting with a patient next week, and that could happen. It could happen in children. It can happen after they've been on the med for a long time. So yeah, just kind of if you see any sort of change in somebody's behavior, check it out. People say it's very scary to be kind of stuck in that. All right, we are going to take a break, I promise. It is 11:25. Let's come back in 15 minutes, please. And we will convene. Go fill up your coffee cup, and we will keep on going, all right? Ashley, are you there?
Who were you calling?
I'm trying to get. I was trying to get somebody, a speaker, Melissa. Sorry, we're working on it.
Okay.
That's all right. Take your time. So. Keep hitting it. Ah, where are you? You stopped beeping. Let's see. You're here. You are here somewhere. Put your is your camera on and your video and your audio on? There you, I can hear you.
Can you see me?
No, I can't see you. I'm hanging up the.
I can see myself.
Wait, I see you now. Now I see you.
Why
See
am
that?
I looking sideways? That's so weird. I'm like, hello.
That wasn't that bad. See, you did it.
I did it.
Is this how you have class?
No, we do Zoom.
Oh, okay. All right.
Yeah, I do Zoom for class and for AA.
Okay.
Well, I mean, I'm starting to go back to actual in-person meetings now, but it is just it's so weird because I usually can like look at myself like straight, but I'm in this weird corner down here, which is fine. That's cool.
And you look
Hi, Ashley.
you look
Hi.
beautiful as always. That's Steve.
Are all the students on right now?
Yeah.
It's me,
they're
Steve.
on a break.
Oh, so they were watching me ride the struggle bus trying to get this thing to start. Cool.
Yeah, a little bit. If you want to make it more fun, you could make it where you look like everyone's in like sitting in chairs. That's the view I have, and you just popped up in a chair.
Oh my God, that's
click
really,
more
really
actions.
fancy.
Yeah, you click up the top, like to leave the chat, like the red button leave. In the middle, it's like 3 little dots saying more action. You just put together mode, and it looks like we're all sitting together.
That's really weird. I clicked on participants, and there's a thing on Zoom where you can like kind of filter your face a little bit so you don't have as many like wrinkles and stuff like that. But I don't see that on here.
Oh, yeah,
Share
we don't care. We don't even brush our hair here, Ashley.
Raise hand, show conversation. Okay, so I'll play with this. And I'll have Tony help me too. She should be here soon as well.
Oh,
She
she
wanted to
coming?
say hi.
All right. So they're on a break for about 3 minutes. So if you want to just, are you ready to talk in 3 minutes, or do you need a time?
I also was gonna, maybe I'll go somewhere where the light's a little better. I was also gonna ask you, like, so what would you like from me? There's like so much to discuss. There's so much in this topic. So are you doing more of like discussing addictions? Are you doing more discussing stigma? Are you like what?
Okay, so it's day 2. It's day 2 of their class. And yesterday I told them they had to go to an AA meeting. So I think just your spiel about, and all the students can hear us talking, that's fine. Your spiel about how to find a meeting, the COVID challenges of finding a meeting, how to act at the meeting. So we have not gotten into addiction or any of that yet, but if you want to share anything, that's fine too. They just got the assignment to go to an AA meeting, and I know your talk always helps them kind of put it in perspective and where do I start with it. So
okay, cool. I'm glad I have a little bit more of a an understanding. So are all the students virtual?
Yeah, isn't this cool?
Whoa, dude, they're so lucky. They don't even realize how lucky they are.
It's hard though, you don't have the face-to-face of the classroom.
Yeah, no, I agree. I agree. I'm doing grad school online, and the whole reason I chose that particular grad school is because it's in person, and it is hard. It is hard because you get distracted. I wonder if I can turn this up.
To roll out of bed. What's that?
I wonder if I can turn this volume up more. My speakers are on.
You should be able to turn your computer volume so you can hear us better, because we hear you pretty good.
It's on full blasting. Okay, I'm gonna go tinkle real fast and then I'll be back.
All right, thank you.
You're welcome.
That's my girl.
Yep. And then I'm gonna go find somewhere with better lighting.
Okay, you tell me when you're ready.
Okay. Okay, I'm gonna I got a lot of batteries, so I'll move this over here.
All right, so for you guys coming back from your break, if you observed all that, that was two educated women trying to maneuver teams. So we're gonna stop. We're gonna leave psychotropic meds for a minute and do something else. This lovely woman who's joined us, her name is Ashley, and she is an ECPI alumni. She graduated in cohort, let me guess, 23?
16.
Get out of here.
Cohort 16, girl.
Yeah, that was a long time ago. So Ashley joins me periodically to talk about Alcoholics Anonymous, and we did talk about it yesterday. It's one of your assignments. So I asked Ashley to join us today to give her. She's a member of AA. It's not a secret, even though she's anonymous. To give her perspective on how to find a good meeting, how to enjoy the meeting, get the most out of it. So Ashley, take it away.
Well, hi. First of all, it looks like we'll probably have some people like kind of joining with us periodically and whatnot. I'd honestly like to start out a little bit different than how I usually do. I'd like to ask you guys any fears or any preconceived notions that you have about alcoholics or about AA. Does this assignment make you nervous to go to an AA meeting? What do you think about all this, and what questions do you have for me starting out? And that'll kind of bridge where I want to go with everything. Everybody
I
feels
guess I'll go
totally
first.
comfortable going to an AA meeting? Liars.
I think I feel comfortable going to it. I think it'll be good because my biological dad's an alcoholic, and I think it'll help me with my like preconceived like notions about like, because sometimes I'm a little like harsh towards it because of him. So I think maybe listening to some people and their stories, it will kind of open my eyes a little bit more.
Yeah, thank you. That brings up a really, really good point. One that sometimes I forget about. There may be somebody in your class right now that is secretly in AA. There was another one, not just me, but actually another guy when I started in cohort 16 that I met at an AA meeting, and we realized that we were going to be starting together the same time just by one of my shares in an AA meeting. He put two and two together and pulled me aside and was like, "Are you going to ECPI?" And I was like, "Yeah, how did you know?" And he told me, so there could be somebody that has information that is anonymous. You'd be surprised at how many people are in AA, and you would never know, from all kinds of different career paths. But what you brought up is huge, because some of you also grew up with parents or loved ones. I mean, I don't know anybody that doesn't know somebody in their family or their extended family or a friend's brother, sister, mother, dad that doesn't struggle with alcohol. It's a pretty common struggle, to be honest. I always say that I'm going to get more prepared and do like the actual statistics of how many people struggle with, alcohol, how many people go into recovery, what's the success rate. Maybe I'll dive into that a little bit more next time I share. I always try to tweak it, but that's a good point. So some of you have parents that are alcoholics and that maybe never got into recovery, or were semi-abusive, and that's a big reason why Alcoholics Anonymous is anonymous, because a lot of people have preconceived notions, and then it bleeds into you as a person. So I don't actually go around discussing the fact that I'm in AA with the physicians or the other nurses per se at my job. It's something that I keep anonymous, and the people in the rooms like to keep their recovery anonymous for the most part, because it can affect employment. It can affect the way that people, perceive you. So that being said, you'll notice that you don't see billboards that say AA here, or call AA, or commercials, or even celebrities discussing AA. They don't typically say Alcoholics Anonymous, because we have a few traditions where we want to be left out of the public eye. We don't want any poster children, because what if that person fails? Oftentimes people do have to go through a few relapses, not everybody, but it is common, and we wouldn't want people to, put that kind of pressure on somebody, because recovery is a lifetime endeavor. You never graduate from Alcoholics Anonymous. So you don't stop going to meetings. You don't ever have all the knowledge. It's something that is a lifestyle change that you incorporate for the rest of your life, because your life depends on it. So that being said, a lot of people don't seek recovery. It's funny, Amber said, I might be a little harsher on alcoholics because of, my father struggling with that. I'm actually harder on them as well when they come into the hospital. When I have ETOH patients, I get really frustrated with them quickly, because I know that there's a solution. I know that there's hope. I know that there's a whole group of people ready to give love and ready to help them walk through a transition, but they're not taking it. So I get a little more agitated with with the alcoholic patients than maybe I should. And that's something that I've had to really work on as well. So anybody else have any questions?
I don't have a question. I mean, I have experience with it. Like, a dear friend of mine is in recovery, and
Cool.
we actually used to like drink together, but
Yeah.
like, I'm not gonna say that anyways, he had a problem with it, and I've helped him like along the way, like in recovery, and it's been a good experience. Like, he has thanked me for always being there for him, because you lose a lot of people along the way in recovery, and I've been to like meetings with him and stuff.
Cool. That's awesome. My best friend is here, by the way. She's also an alumni. This is Tony.
Hi.
We kind of like go everywhere together. I haven't seen her in a long time, 'cause she's been doing overtime contracts
Hi,
in trauma
Tony.
ICU.
Hi.
Are you alone? Where's Oz?
I'm alone right now. He's sleeping.
So Tony has a therapy dog named Oz. Maybe she'll talk about it later, but he detects her diabetes. And Oz was in every class at ECPI. He went to graduation.
Mm-hmm.
You got more claws than anyone else, actually.
Yes, we love Oz. They have an interesting story. So maybe when Ashley's done, Tony can talk for a minute.
All right. So, yeah, those are all really good things. Knowing somebody in addiction, supporting people in addiction. I'll kind of give you an overview of what AA is, because it sounds like that's what Dr. Green would like me to discuss. So AA is an organization of, men and women who come together for a singleness of purpose, which is to get sober, whether their lives have completely crumbled due to alcohol, or whether you've suffered some serious consequences, or you've been court mandated, or you're a healthcare provider like this and you're going just to learn. AA is a safe haven of recovery, and people get together at various locations. It's easy to find Alcoholics Anonymous. You just Google your area. There's hundreds and thousands of meetings all over the place simultaneously going on at all times of the day. You can find a meeting anytime, any hour, anywhere, pretty much. So just hitting find meeting near me. There's apps. There's one called In the Rooms. That's a good app that a lot of us use. And it calculates your sobriety. It calculates how many minutes, hours, days you have of sobriety, and it gives you your reading of the day, because we have it's hard to discuss it in such a short amount of time, but we have a routine of things that we do, because AA is a 12-step program. You not only go and work the steps with a sponsor, which clears out a lot of like past traumas, past resentments, various things that could keep you in the mindset of trying to self-soothe with alcohol. But that's not enough, because alcoholics, like myself, have a mental obsession and a physical allergy. That's how it's described in the book. And that's really the only way that we can really describe it. That mental obsession of, I got to get home, or I got to get something. And the fact that alcohol does not react normally in the body is the only way in which we can really describe it. And that was written by a physician and added into our book from when our founder was very sick. And he goes into how his journey of recovery in our big book as well. And this is our big book. I have actually a case for it or whatnot, and then it has all the steps, and the steps are basically just a guide to living that works, because just putting the drink down or just getting sober doesn't really change anything. We believe that that is just a symptom of a mental illness. So just putting the drink down doesn't automatically make you a productive person. It doesn't make you a productive member of society or a good person. It's just what we were using to escape life, if you will. So a lot of people will choose something else after that, like sex, shopping, eating, whatnot. There's 12-step programs really out there for everything. There's hundreds and hundreds of 12 steps to help you with codependency, Overeating Anonymous, Narcotics Anonymous, Marijuana Anonymous, you name it, because these 12-step meetings believe that singleness of purpose is what creates the unity of the group. So in Alcoholics Anonymous, even though we've got a lot of drug people coming in, because AA is such a great support group and great recovery scene, we get a lot of other people. Like my husband, for instance, is a recovering heroin addict. He goes to AA, but they want you to keep your focus on alcohol. So he may say my drug of choice, or he may say alcohol, but he's also incorporating what we call dry goods into that. Yeah, so that's basically it there. Alcoholics Anonymous doesn't take any stance on politics, religion, anything like that. It's run completely by alcoholics. We're also not allowed to take any contributions, like big money contributions from organizations, because we believe that we have to be self-supporting through our own contributions. If we don't have any skin in the game, then we're going to end up being spoiled and not as involved in our recovery. So a lot of times you'll see a basket passed at meetings, and even though it's not in the book, there's like little etiquettes that you learn. You don't have to give anything to the basket when it goes around, but oftentimes we will all give $1 is typically what we try to give. Some people give more. to keep the lights on, to keep everything functioning, to keep books being purchased so that we can bring them into jails and institutions, or to other places where people, need these things. So it's a really cool place. There's so much that is involved in it, goes into it. If you want to learn more, you can Google it on the internet, and it's got some great stuff. I actually just printed out a bunch of information for a young guy I had, 25, alcohol abuse, clearly, and was suffering, seizures from trying to detox and whatnot. And I printed out AA for young people for him, because I think that a lot of times, or maybe I shouldn't even say this. I mean, me, for example, I thought alcoholics were dirty people that lived under the bridge. You know what I mean? Like, they're not educated people that come from good families. My parents are not alcoholics. My brother is not an alcoholic. I do have alcoholics that run in the family. I don't try to overly think or process whether or not I believe that it's genetic. I believe that there is probably a genetic component. But something is different about my brain, that when I drink alcohol, everything changes. All bets are off. I don't know how much I'm going to drink. I can't stop once I start. The consequences are great. I black out. Everybody has a different story, but to be a member of Alcoholics Anonymous, all you have to do is just have a desire to stop drinking. You don't have to say you're an alcoholic. You just say, I have a desire to stop drinking, and I'm here to listen and to learn. And you'd be surprised. The longer you stay, the more you hear like your story, because it's against the grain, man. Like, what alcoholic, wants to go and say, I want to stop drinking forever? Nobody does that unless the pain is great enough that you're motivated to get willing to say, okay, if this is the only way out, then I'm willing to listen, and I'm willing to see, what people are saying and to see their experience, strength, and hope. So that's what people do, is go around the room and discuss their experience, strength, and hope, and how they got to where they are in sobriety, and how their life looks completely different today. So it's really cool organization. Tony's been to a lot of meetings with me. She's helped me also serve Thanksgiving dinner there, Christmas dinner, things like that. Also, one other thing I wanted to discuss is open meetings versus closed meetings. So when you go on to look at whatever AA meeting you want to go to, some will say, now they have all kinds of things for various things. They've got just women's meetings, just men's meetings, just gay meetings, just whatever. But open and closed are the main ones that you'll need to look at, because you'll be going to an open meeting. There are certain meetings that are closed, which means for only people that are alcoholics. And that's to protect anonymity as well. Like, some people really don't want outside people coming in because they don't have skin in the game. Like, they could go out and say, hey, I saw Dr. Jones at an AA meeting, or I saw Lawyer Bob at an AA meeting, and that could affect their livelihood, their family, various things. So you'll go to an open meeting, and that's where a lot of people start out going to meetings as well. Like, if somebody's scared to go to a meeting, kind of like what Melissa was saying, she supports, one of her friends in recovery and has gone to meetings. Most of the time they won't kick you out if it's a closed meeting. I mean, if they don't know that you're a student or whatever, and you're not sharing or whatever, then they would never know. But it's considered etiquette to go to an open meeting. What else? Anybody have any questions?
Ashley, they should identify themselves as a student. Don't pretend you're an alcoholic. You don't have to play the role.
I mean, to be honest with you, you don't necessarily have to. say that you're a student. You can just be a quiet observer, but I always like when people identify themselves as students, especially if you're going to write things down. A lot of people write things down in meeting as is. Like I've brought in, my step workbook and, written or I've jotted things down before that I liked somebody, share. Just a couple of key ideas to help me with my sobriety. But if you're at an open meeting and they always ask at the beginning of the meeting, is this anybody's first meeting or do we have any visitors today? You can raise your hand and say, hey, I'm a nursing student. This was a requirement for my class. I have a little notebook. I'm not taking down, names. I'm just, writing a couple things down. I hope everybody feels comfortable with that. And that's it. I'm just here to observe. People love that. You'll probably get flooded with people after the meeting, like intrigued by, what you're learning and how they can help and all this stuff. Because a lot of people are really, really passionate about, their recovery and being as helpful as they can. So, yeah. Anybody have any additional questions about anything?
And you guys can wear jeans and just jeans and a t-shirt. You don't have to wear a uniform or anything like that.
No, you can
Just
wear whatever you want. Yeah. Has anybody
Funny-
gone to one yet? Has anybody done the assignment yet, gone to one? Or is anybody freaking out like I feel really uncomfortable going and I can't go unless somebody else is with me? No. Bueller.
They're
Me and Alexis
brave.
are planning to go tonight.
Okay, good. Did you find a meeting?
Yeah, we found one here in Sanford.
Okay,
Cool.
good.
My
Yeah.
home group is Central Orlando Group in Orlando. It's downtown. I go to that one. They have meetings at 6. They have meetings at 8. The noon meetings are really popular there. But I don't know if noon meetings. Yeah, I don't think those are open. But on Saturday nights, there's a speaker meeting. Those are always really good, and those are open. They start at 8. I actually speak there the second week of February at 8 o'clock as well. So those are great meetings to go to. There are a ton of them. So I'm glad you guys aren't feeling too nervous because I feel like a lot of the people in class my class were really nervous about going. They were like, what do I do? What do I say? It seems kind of awkward, and it definitely feels awkward when you walk into your first one because you don't know what's going on. You're like, who's in charge of this? And like, there's a coffee bar and there's a lot of weird people, not weird people, but we always joke in AA that we are people that would normally not mix. So like you've got, like people that look like me, like a sorority girl. And then you've got, Joe Schmo from the corner. You've got a couple people that are homeless. You've got a couple lawyers. You've got a couple of really everything, like people that, and you'll see them, like loving on each other like family. And we always joke that we would have never met each other had we not all had a common, reason to come in. So it's kind of cool.
You guys, funny side story. I have a very dear friend who's an addict, and she's a Disney freak. That's her biggest fault right there. But she was coming down a couple years ago. She's like, you got to find me a meeting, because her and her husband are both in recovery. There are actually meetings inside Disney every day.
Oh, yeah.
Yeah. So happiest place on earth still has an AA meeting.
I mean, they even have incognito AA meetings on cruise ships. And they have them in the airport. They literally have them in so many different places. They're just incognito. Kind of like how I just said, there's no nobody's ever seen a billboard that says Alcoholics Anonymous, or have you ever really seen a building that says, Alcoholics Anonymous on the front? I mean, there are places where you'll see like our symbol and you'll see AA, but most of the time they have, like incognito names, and you'll realize what those names are when you Google find closest meeting near me. Like I remember there was one right next to my college because I first went to my first AA meeting when I was 23, and I passed this door constantly and didn't know what it was. And all it said on the outside of the door was "Show Me Group," and I was like, okay, like. So when I got online, it was like Alcoholics Anonymous, and then it has a meeting name like Show Me Group or Happy Hour or whatever, Central Group, which is mine. It says Central Group on the outside. Nobody knows what the hell Central Group is. You know what I mean? So it's kind of cool. You still feel like protected. You still feel, a little more incognito, if you will. Which isn't really my thing. I'm starting to get more and more like vocal about it because my end goal is I want to be a psych nurse practitioner. That was always my goal. Coming into nursing school, I always wanted to go into psych, but I knew it was going to be kind of a long journey to get there. And now I'm starting to finally make, some strides with it because I'm in graduate school. And I'm trying to find something part-time at a behavioral center or a detox center. I work for Orlando Health right now. I'm in intermediate critical care, and they can't see what I'm doing.
You're staring at it.
I'm in intermediate critical care, but I will go after I graduate with my FNP. I'll apply for a post certification in psych so that I have not just my psych NP, but I've got a couple of options. But I also know a little bit more about peds and adolescents because that's where I'd like to specialize in. So I'm kind of an open book, like about my recovery a little bit more now. Like I don't discuss it with the doctors, but there's several nurses that know that I'm in recovery, and because I've been able to prove, my how well and competent of a nurse I am, and I've been able to prove my sobriety, people are often really surprised now that it's been like 3 to 4 years that they've known me that, I'm in recovery and I don't stop going to meetings. You never stop. You continuously go. So it's something that I've been able to help other nurses with too. There's high addiction rates in nursing, doctors, nurse anesthetists, all kinds of people. So it's just a really interesting field. And then I also usually like to give my information at the end of this too, in case anybody needs to talk about whatever. Sometimes people reach out to me because they're hurting over a family member and they're like, how do I have a happy life and deal with my alcoholic mom or brother? How do I stop obsessing over worrying about him? Or I like to call myself a heavy drinker, but I've been suffering some consequences lately. Like, what do you think about this or whatnot? So I'll give my information at the end just in case anybody wants to keep it and reach out or has any additional questions they were too embarrassed to ask or want to add me on Facebook. You can always shoot me a message and just ask me something private or whatnot. So I can do that.
Ashley, when you do that, you can put it right in chat, but could you also put the date that you're speaking? There might be somebody who wants to come to that meeting. If you don't mind.
Totally. Where?
In the chat.
And the most
Yeah, no, I
startling,
will. Is that my phone? Okay, I have to look at the.
startling thing that you said was husband.
Oh yeah.
Ashley has a new husband. Ashley
Well,
just
I've
got
never had
married.
one
That's I'm
before.
teasing.
Like
Huh?
like as a new I haven't had a husband before. So yeah, I got married. I eloped in August in a tree house in Washington State, and then we had a party like a month ago, like really just like ended December, because my family wanted a party, and so we ended up having a shindig again, and it was really fun. But yeah, these are the promises of staying sober. Like I never thought I would. Definitely never thought I'd be married. I actually wore one of my old dresses from 7 years ago when I was about to marry a fellow alcoholic. We were both drinking and it was a freaking mess, disaster. So I had hung on to that little piece, but life is good. Life is really good sober, but there's a lot of things that young people struggle with as well. Like we were just talking about it on my AA Zoom meeting yesterday. It's a women's meeting, and we were talking about sober sex and how that's like a really scary thing for young people, because most of us that have drinking problems have never had sex sober. And you're like, how do you even do that? Like, what do you even, oh my God, like everything, or how am I not going to drink, you know, at my wedding someday, or all the things that people think, or how am I going to find somebody to date? Nobody's going to want to date me if I don't drink. Like all those things that we, all those fear-based lies that we tell ourselves, you know, in our head to keep us from realizing, you know, our potential. So anyways, let me look up I'm gonna have to figure out how to put this in chat as well, but okay, cool.
Believe me, you can do it. Ashley, what's the deal with COVID right now? Are things still online as far as meetings, and some are opening back up?
Yeah, so the meetings were always still up. It's actually caused a huge rift in AA, the COVID stuff. This is the only time that I've felt like there's a big divide in AA, because it's very, very rare. But a lot of people have been fighting over, you know, whether we should mandate masks or not mandate masks, or keep the clubhouse open or keep the meetings open, or if people feel safe. So a lot of meetings are on Zoom, but we also have our in-person meetings. They're just a little bit more scarce than they used to be, but you just would need to follow the rules. Like all the rules that we have at each individual location are different for AA, because your group as a whole decides what the good of that group is. So we have business meetings once a month where you can volunteer to go, and it doesn't matter if you have 1 day of sobriety or you have 38 years of sobriety. Everybody has an equal voice, and you go and everybody votes on certain things. So our meeting and our people voted to require masks at all times in the meetings. So we do that. So I recently started going back to in-person meetings, and I'm really glad, because it was affecting me mentally, not going to in-person meetings. I was starting to get really lazy in my program and using COVID as an excuse to just focus on school, just focus on work. But without sobriety, and this is what my sponsor told me, without sobriety, you're going to lose all that anyway. And that is true, because I have relapsed several times in the 11 years that I've gone to AA, and typically it's been because I thought that I knew it all, or thought that I graduated, or thought that I was smart, or spoiled by my blessings. And then I'm like, oh, you know, I'm good. I can just have a glass of wine. Like I've been sober for this many years. Like I'm fine. And then all hell breaks loose, you know, within a week. And I'm like on the verge of losing everything, you know? So, yeah, let's see what,
Ashley, if you click on that little thing that it says show conversation, it'll come up and you can type something in there on the very top next to the little people, and between the people and the hand.
One more over.
That?
Click.
Okay.
And then you can type your name and number in there, and any information you want.
Oh, cool. Yeah, it just popped up. All right. Well, first of all, let's see. Okay, so all right, so let's start with just my name. You can find me on Facebook by my maiden name or by my married name. Both are on there. I'll give you my number. You can text me. Texting is the best way to reach me. And then I'll give you date of when I speak. So I speak. p.m. Was that February 13th? Yeah. Perfect. Okay, so that's the information right there. So one last thing before I take any questions or get redirected somehow by Dr. Green, whatever she needs. So how does this, relate to helping people in the hospital? So you'll find that alcoholism is kind of a strange thing. So people in AA diagnose themselves with alcoholism. Only you know if your life is crumbling down. Everybody has a different bottom. Everybody has a different pain threshold for consequences and whatnot. So if you're in AA, it's because you're hurting. Nobody comes in on a winning streak. And you have to be the judge of whether or not you believe that you have a problem with alcohol. Now, in the hospital, we call them ETOH patients, and then we say like history of alcohol abuse. That's what we call it there. And then there's a certain criteria, like if you have more than 4 drinks as a woman a night or whatever the criteria is. They have to quantify it somehow in medicine, so it's a little bit different. I did print out a quiz that I found, or like a questionnaire that I found out online. I believe it was through AA, but it might have been through Orlando Health, where it says if you answered yes to any of these 7 questions, then you have a problem with alcohol. And so I actually gave that to my guy the other day and printed out a bunch of stuff. But I always say, listen, this is your life. Only you know if you're happy. Only you know if it is unmanageable. But there is a place where people have found hope and strength and a completely new life and untapped potential, and it's AA. If you'd ever be interested, you can go and listen. But here's some information about it, and I just straight up print it from the internet. And I just think, after that, they can do whatever they want. I've also given patients that are crying and saying, I need to change, that's a great time to just give them the 1-800 number, somebody to talk to. That room is pretty boring at the hospital. It's white, it's boring, there's nothing to do. And if they don't have anybody enabling them or telling them they're fine, then it's a great time to give them just that 1-800 number. Just say, hey, there's somebody on this line at all times to talk to. And maybe it'd feel good just to talk to somebody who understands. Nobody's going to tell somebody that they're an alcoholic. We don't get anything from recruiting people, and we don't. And that's another reason why you don't see AA on any billboards or in any advertising fashion, is because we believe at AA that it's attraction rather than promotion. So we go out just being the best version of sober, hardworking, kind people that we could be. And we work really hard to constantly improve ourselves in that sense. But I don't go out and try to recruit people or try to tell people, because there's no point. That is just a waste of time, waste of energy, waste of emotion, because people aren't going to get sober unless they are willing, unless they are hurting bad enough, and or have seen somebody else do it and they're like, damn, I remember when that person was a crap show, you know what I mean? And they were a total gutter drunk, and now they're like doing this and doing that. I mean, they look totally different. They act totally different. So it's interesting to see, and it's really cool to watch people come in and their lives transform if they stay and if they're willing to be honest and do the work. So anybody else have any questions? No. How many people are on this thing?
How long does the meeting normally last?
Oh, meetings last an hour. Good question. It starts by somebody reading what AA is, and they'll read some kind of excerpt from the big book. It'll either be more about alcoholism or how it works, something of that nature. And then there's a couple of announcements that they do, because we have a lot of events that we do together, and they'll pass the basket, and then the chairperson will share like maybe a 5-minute share on their experience, and then they'll pick a topic. So topics could be anger, resentment, fear. There's all kinds of different topics, and then people will go around and share. And like I said, every A meeting is completely different in how they format their stuff. So sometimes people raise their hand to share. Sometimes it goes in clockwise order. So don't be scared if you start noticing that the people next to you are sharing in order, and then it gets to you and everybody just stares at you. You at that time can say, oh, I'm just here to listen, or I'm a student and I'm just learning, hearing some really great stuff, or whatever. So sometimes it may come to you, sometimes it may not. Depends on what the format is for that meeting.
And there's people, that's a good question about the hour meeting, but there's people that go to 3 or 4 or more a day. This is how people keep themselves sober. That's why
Oh yeah,
they go all night long. Oh yeah, all night
oh
long.
yeah.
Or
Some people go to 3 or 4 meetings a day because they're struggling so bad, and they don't know what to do with their time yet. Like I said earlier, like just putting the drink down is like 1,000th of the issues that go on with alcoholics. Like they don't know, nobody knows how to be like a mature human. No, sometimes we don't even know how to act in our jobs. Like when you've been using a substance to screw your mind up all the time, like you don't even know how to be a player in life. You don't know how to really do anything. So we always joke that our maturity and our growth has been stunted. So whatever age you started drinking at is what age you are when you get sober. So a lot of like 40-year-olds are like, I'm 16, like I'm a 16-year-old, like and you learn how to be a good member of society, how to be a good daughter, how to be a good wife, how to be a good friend. Like there's so much that AA teaches you that it would be great for anybody. And if anybody happens to go to a really badass meeting, which I hope you do, some are better than others, some are crappier than others, but if you go to one and people are really, really sharing some great stuff, you'll be like, damn, this is awesome. Like I remember my brother's a normie, but he came to a Thanksgiving meeting one time, and he was like, oh my gosh, like the things that people share are crazy. Like, I can't believe that. I can't believe that person was so honest and shared that. He's like, this is really interesting. I feel like I could apply these things to my life. Like, and I'm like, you could apply to the 12 steps to anything in your life. And often people do, after, like people in AA will start to utilize those 12 steps for anything that they're fearful of, that they are obsessing over. That's the beauty of it, is that we use it in so many different capacities. You use it throughout everything in your life. So, but yeah, at the beginning, it can be rough. I used to go to 2 or 3 meetings a day at the beginning, because I did not know what to do with myself. And all my friends were in hospitality. They were all drinking at the bars, and I didn't know how to fill my time. So I would go to as many meetings as I needed to, until I started feeling relief from the mental and physical obsession. Yeah.
I have a
Any
question.
other questions?
Actually, there's.
Oh, I have a question too.
Do people, or is it common that, let's say, people that drink, or they get intoxicated and then they get the guilt trip and they're like, okay, I have to go to AA meeting, and they come intoxicated or they come hungover, and
Are you asking if that's common or if it's okay? Or
I mean, is it common? I mean, does it happen?
It happens. It doesn't happen like super often, but I should be careful about saying that because I'm only speaking about my experience, and I really only go to my home group because they have so many different times for meetings, and it's really close to my house and my friends go there. But I mean, that being said, 3 days ago, a guy a guy came up after the meeting. We were all standing outside socializing for a second, and a guy walked up and was completely tweaking out. Like he started just rambling about how he just hit a crack pipe and drank a few beers, and how he said a lot more than that he really didn't need to share. But either way, like I was like, well, what's going on? He's like, I feel so bad. I feel so bad. And he was like freaking out because he's tweaking. You know what I mean? I was like, okay, well, what do you need? And he's like, I really need a big book. And I was like, okay, come inside. And so I bought him a big book or whatever. And I introduced him to the guys because the guys tend to stick with the guys new in sobriety, and the girls tend to stick with the girls new in sobriety for obvious reasons. And so I introduced him to some guys, and maybe he'll sober up and come back, the next day. He had said that he had already been to 2 meetings that day. So, and I've definitely seen people that have relapsed go into meetings drunk that, had several years, and they just know that that's where they need to be. I definitely went to a meeting hungover. The last time that I had a relapse, my now husband and best friend sitting on the couch forced me out of the house to go to a meeting, and I did not want to go because my ego was telling me I didn't want the people in AA to know that I had relapsed, and I was feeling just so crappy and so shameful, and so they forced me to go, and it was really embarrassing. I cried the whole time and sobbed the whole time, and my bones hurt. Like it was, oh God, it was an awful day. But yeah, I mean, it's recovery at the end of the day, so it can be pretty or it can be ugly. If somebody's being disruptively drunk in the meeting, usually somebody will like kindly, like, just take them out and be like, hey, you want to go outside and talk with me, and you can smoke a cigarette, and usually they'll be like, yeah. And you go outside and you just like kind of talk to them, get their number, make sure you follow up with them and whatnot. But they're not probably hearing anything in the meeting anyway, so it's best to have somebody go out and talk to them. But yeah, if they're not disrupting anything, they come in messed up. Mm-hmm. Anybody else?
So my question is, the meetings I've been to were out of state, and they always had like a leader like for that day who like chose the topic. Is that how it is here in Orlando? Okay.
Yeah, so that is a similarity with all AA meetings, is that there's always a chairperson, and typically the chairperson rotates because there's nobody in any authority position. Everybody is considered equal in AA. So how that person becomes a chairperson may differ at other meetings. Like for ours, for instance, you make a year requirement to chair a meeting. So, and that's considered service work, and it helps keep you sober and accountable. So it's a really good idea for it's a good idea for anybody to do. I've done it. In ECPI nursing school, Sunday was my only day off that I knew that I wasn't going to have an overnight clinical or a day clinical or class or anything. So my sponsor was also an RN who was just about to graduate with her nurse practitioner, and she was like, it doesn't matter how busy you are. I know that nursing school is hard, but you need a service requirement to keep you in the middle of the boat. And so you need to choose a meeting to chair, and you need to do it for a year. And I was like, I don't have time. I'm freaking out. And I ended up doing it. And my meeting to chair was 8 p.m. on Sundays, 8 p.m. meetings on Sundays. And there were usually only about 4 people. And the same 4 people would come every week. And that's also an open meeting, the 8 p.m.s on Sundays. So yeah.
Yeah,
that
so
was
you
fine.
just not so much like a leader, but yeah, like everyone shares kind of like the responsibility, and then like
Yeah. So
Okay.
there's always a chairperson. So the chairperson is the one that's kind of in charge of making sure that people don't crosstalk, making sure that people are respectful, getting people back on topic, or keeping track of time, going over the announcements, and that responsibility is shared, as in like maybe they're the chair that week and then there's a new chair the next week. It depends on what meeting you go to, or maybe they're the chair for that meeting, that hour in that week for the next year. Like that's just what I know my home group does. Some people do it differently, and then there's also a list of people that have met the requirements to be a chairperson and can't make that kind of commitment, but are there for when somebody gets sick or when somebody goes out of town, and so you can call that that list to have a fill-in. So that's also an option. Good question.
So the groups you guys will be able to see in clinical, they are run by a professional. This AA is considered peer-to-peer. They run themselves, I guess, basically.
Yeah. Yeah, it's a really quirky, strange little organization. It completely runs itself, and it's totally bizarre and weird, but it works. And yeah, it's pretty cool.
Any other questions for Ashley?
No, but I was just going to say thank you for sharing.
You're welcome. Thanks for being here. Thanks
Yeah,
for all your questions.
You're beautiful as always. There are 34 people here, you were wondering. And I'm going to share Ashley's wedding picture because it's so beautiful and I'm so proud of her.
Oh, thanks.
She is awesome. Tony, you want to talk for a minute?
I can.
Thanks,
I look like
Ashley.
a tired mess.
You're welcome. Bye, guys. See ya.
Hi, friends. Let me get out of the sunshine here. Wow.
Tony?
Do you want to be on this side? I was like very, very bright in the background. That was all. You had a spam call. That's what I had up, by the way. Okay.
I'll get you some water.
I'm okay, Ash. Thank you. Hi, everybody. So, my name's Tony. I am a nurse that graduated from ECPI. I have a service dog who attended class with me every day. I've had him since I was a couple months into being 18. He's been with me my entire adult life. I wish he was here. I was gonna bring him, and then I was like, no, I have things to do later. So I got Oz because what is up with your lighting, Ash?
I know, right?
It's very strange.
Here, hang on.
Okay.
It's better when I do this.
No, because that's so bright. Okay. Sorry, friends. I'm not nearly, there we go, as good at balancing things as Ashley is.
There.
So I got Oz as part of a research project. He belongs to an organization that does research out of Virginia and Colorado. So he was trained in Colorado and then brought to me in Florida. I originally got Oz my freshman year in college as like a last-ditch effort to not move back home. My college experience was like anyone else's. Like I left home, I moved in with a roommate, did the whole thing, and my roommate in the middle of the night had consumed all of my juice boxes innocently and was just like, oh, I'll replace them later. Well, I went low in the middle of the night and passed out in the kitchen because we had no food. Because we were in college and we all know how it is, like, especially when you're new on your own. So her boyfriend found me passed out in the kitchen with pots and pans around me because I was so low. I thought, where could food be hiding? And pots and pans was the answer in my stupor. So after I made it to the hospital, my mom obviously showed up and she was like, there is absolutely no way you're living on your own. You're moving back home. We're going to have to rediscuss all of this. And I told her no, like I'm an adult at this point. I need to move on with my life. I need to continue to grow. And so the dog was like a compromise for us. So my mom had done all the research on it. I was diagnosed with diabetes at the age of 5 at the Barbara Davis Institute for Childhood Diabetes in Colorado. And the research project was through them. So Oz was trained by scent. So everything he does is based on scent. I had to send samples, mouth swabs, water bottles, clothing I was wearing when I was low to his trainer in Colorado. And she trained him specifically to alert to low blood sugars originally. His alert for low blood sugars is to bark. He gets really excited when he does it because he knows he's going to get a treat, and he like dances, and then he'll bark at me. So it's very obviously, very obviously like, hey, this is, hey, I get a treat and this is the time I get to shine. And he gets very excited about it. So everything is based on scent. He is also night trained, which means that he will alert in the middle of the night. And then as training goes on, once you have your dog, they're able to tell like what your normal scent is, so they can also alert to highs. So his training to highs for me is he will lick the center of my hands. It's random, but usually highs are, slower growing process than a low. So it's not always an immediate change in scent. He is, I wish he was here. He's like a 100-pound lab.
For like a really cute picture of him right now.
So he is a 100-pound lab. And part of the reason that I got a lab as a service dog, they train everything from Pomeranians all the way through German Shepherds to be service dogs. There's no one type of dog that is the best kind of dog or has the best sniffer. But I am not someone that looks like they should have a service dog, quote unquote. So a lot of times when people think service animals, they think blind people. When I was in college, I had an experience where I had a gentleman open a door for me, and I looked at him and said, thank you. I had Oz. We were on our way to statistics class. And he said, I'm an asshole. And I said, why? He said, you're not blind, are you? And I said, no, I'm not. And he's like, why do you have a dog if you're not blind? And I had to explain everything to him. But he wasn't an asshole for opening the door. He just, made a couple of assumptions. So I have had numerous experiences where people have looked at me and said, that's definitely not a service dog. You're definitely lying. I've been in restaurants before where managers have approached me and said, hey, pull your dog out from underneath the table. I don't believe he's a service dog, even when he is identified with a vest on. Even when I have paperwork that is not required by law to carry, people still question you. So I highly recommend all of you think about the way you approach people in the hospital, and you will have people who come in and say, oh, this is my support animal. Oh, he's a service dog. And they really aren't. And it's very obvious that they really aren't. They're like peeing on the floor, and you want to do the best you can. So as of now, which the laws are changing shortly, I am not required to identify my service dog as a service dog when we go in public. I do it as a courtesy. He wears a vest anytime we are working, is what it's called. So if we are in public, if we're in a store, he is working. And there is 100% difference between my dog in a vest and my dog not in a vest. He will still work when he's not in a vest and we're at home. But when it comes to being in public, he like turns into an officer. So children are no longer fun to play with. He ignores every other dog in the room. Like he's very centered on what he's doing. So he's so sweet. What else can I tell you?
That is so amazing.
He's so awesome.
He has saved your life. He has saved your life several times.
On numerous occasions. And it's interesting because I don't think he realizes, obviously as a dog, like the kind of impact he has in my life. But he's 12 now, and I have a giant fear of him like passing away because he's been with me my entire adult life. And I rely on him so heavily. So he is considered a tool in my toolbox. I'm allowed to use my tools appropriately. I have lots of them. So he's not always with me, but he is with me anytime I'm not around chemicals, or sometimes at this point I leave him home when I run errands because he has a lot of arthritis. Being an older pup, and like right now with it being cold, he's not as apt to moving around and jumping out of cars, but it just depends. So working at the hospital, I am allowed to bring him with me. They cannot tell me no. But for his safety, I don't. I work in the trauma ICU, and I can't imagine trying to mass transfuse someone with my dog in the room. He'd probably be a bloody mess. So, you know, I try to think about where he is in the environment and his safety as well.
Tony, tell him about his brother.
Okay, so like I said, Oz is part of a research project. There are 6 dogs in his litter that were trained. All of them have amazing noses, genetically, I guess. And Oz's brother was trained the same time he was, and was given to a man who was very into hiking. So the dog would go with him hiking all the time. The owner had traveled down 6 miles away from home, near a stream in their house, and they live in Colorado. So nature walks and being able to go through the woods is pretty common there. His blood sugar went low, and the dog was not with him at the time, and he ended up passing out down by the river. The wind blew, and the dog was able to pick up on the scent from 6 miles away and locate his owner to bring him help. So the dog, I guess, was freaking out in the house, barking, trying to get outside. So eventually they let the dog out, and the dog just went running. The family finally, like, it didn't take long to trigger, like, oh wait, he's gone, dog's gone, like something's going on, and they were able to locate the dog and then the owner and save his life. So it's pretty amazing.
Can you guys see this?
Aw.
There he is. Yeah, when he has his vest on, it's all work.
Yeah, that's him and Tony. There's Tony in the purple pants. And there's Ozzy.
That picture is actually on the wall at ECPI in a newspaper. So if you ever see it, that's who they are. So he Oz will go to has gone to your neighbors and woken them up when he hasn't been able to wake you up.
Absolutely. And when I had roommates, he was very apt to just leave the room and go get my roommate if he couldn't get me to wake up. To this day, he still barks and will leave my house. He knows how to open doors. My neighbors all know who he is and what he does. So if there is an emergency and I decide to pass out on the floor, he is able to go get help. He's funny now that he's older because he will open doors at his own accord. If he just wants to go outside, he will. But like I said, my neighbors all know who he is. So if he's in the front yard chilling, they always come and make sure I'm okay. But yeah, he's trained to go get someone. He's also trained to like collect a juice box if I need it, if I am just weak and, you know, still alert. And I'm lucky in the fact that he has the cognitive ability to know the difference between, hey, I need to grab her juice box, and hey, she's out, I need to go find somebody else. So he's great.
And he does alert on other people. So you've had some interesting experiences with him.
Absolutely. So anytime your blood sugar is altered, obviously when you drink, your blood sugar usually goes low, actually. And I've taken him in public before. Downtown Savannah, Georgia was the first time I really had an experience where we were around a lot of drunk people, and Oz could not figure out who he wanted to alert on first, last, and second. So he was just barking at everyone. And it's very hard to explain to drunk people why your dog is barking at them. Also, when we go in public and he alerts on other people, we're like walking through Walmart and, you know, he alerts on someone. It can be very hard to approach people and say, hey, are you a diabetic? Or, you know, I know you are missing 3 of your toes, but my dog thinks your blood sugar is high. You know, you can't really approach people. It's hard to start those conversations. So I've definitely had some interesting conversations with people in public about, hey, sorry, he's barking at you. And they'll be like, why is he barking at me? And I'm like, well, you're either intoxicated or you have an issue with your glucose. So it's fun.
I love having Tony talk with you guys first of all, because they're amazing, but they're using so many support and therapy dogs in mental health. So that's something you may read about. You might want to do your research project on that. They're teaching dogs to, if the owner has schizophrenia and is hallucinating, they will nudge them and tell them they're acting bizarre out in public. Obviously, panic. A dog can support somebody during a panic attack. It's just amazing.
Seizures. I've seen seizures.
I had a patient a couple weeks ago who had a dissociative disorder, and the dog would lay on top of her to bring her back to reality. Basically, when she would dissociate, the dog would lay on top of her, and the sense of the dog being on top of her is what brought her back to reality. It was very cool.
Oh, that's awesome.
Yeah, I am always amazed at the intelligence of dogs and other animals. I seizure wise have seen, they train monkeys to bring people to the ground. Dogs, what are they called? Miniature ponies have been trained, especially for people who require support, like people with seizures or disorders where they may fall over or need extra support, ALS, things along those lines, to help them walk. Yeah. It's amazing.
Any questions for Tony?
I'm sorry he's not here so you guys can meet him, my old man.
He was in every class, every mental health class.
Yes. And we had a classmate that would feed him beef jerky and pretty much whatever she was eating, and it gave him the worst gas. So everyone got to smell the dog. It was terrible.
I knew when it was time for a break when everybody started fanning. Well, you ladies are beautiful as always. I still owe you dinner. And thank you for joining us. But you guys can see you will get through this program, and you will be nurses just like these guys were.
Tired nurses.
Cohort 16. Wow, fine nurses.
That being said, by the way, is anybody like dying in nursing school right now? Like anybody like this
Yes.
is yeah.
Yes.
Whoever said that is being honest.
Yeah, we cried a lot, let's be real. Do you guys have any questions about the program we can answer for you, or about getting a job, anything along those lines?
So the president of cohort 25 told us that, like, in our little SNA meeting, that like quarter 3 like gets a bit easier, like that, like 1 and 2 were like the harder ones, and then like 3 kind of gets easier.
Wait,
Like,
wasn't 2 easier for us? Like, I don't know if it's still the same structure.
One was the worst, and then they progressively got a little. 2 was still difficult.
Okay.
3 is when we did OB, and you
it's
hated
med
that.
surge, so like some, like med surge was like the bulk of 2. And
Yeah.
then but public health gave some people some problems as well. But then like now she says like it kind of like gets easier like as it goes. Hopefully. Maybe.
I'm gonna be honest. I don't know if it gets easier. You just get used to it.
Yeah.
So, you obviously the first semester and second semester, you're getting into a pattern of studying and sleeping and going to clinicals. By the third semester, you're like, yeah, I've got this. Like, you know how to study. You know how to get through the material in a timely manner. You're still going to have your moments where you feel like you're in quicksand, but I think definitely the first 2 semesters prepare you for the last 2 semesters. Just don't sleep on it, because things will catch up to you.
I have a question on the pathway of nursing that you're at now. So one of you guys mentioned you do trauma ICU. So what did you guys, they always say to do med surg nursing right after graduation, but I'm curious to see what you guys did after and where you guys are at now. Within like how many years have you guys graduated now?
It's been 3.5 years since we graduated.
Okay.
And I did start on a med surg floor. I started on 10LP, which some of you have done clinicals on, I'm sure, at ORMC, which is a trauma colorectal floor. It is honestly, as someone who started in med surg, I can tell you I have 1,000 more skills than people in the ICU do. And I can tell you, when we get those mass traumas, I'm the one who can get the charting done in 2 minutes because I had to chart on 7 patients before. So they will literally call me into the room and be like, hey, can you get this charted real fast? Because no one is as fast as I am. No one can drop an NG tube like I can. Nobody can dermabond wound shut faster than I can. You have skills that you learn on med-surg floors. And everyone's like, oh, med-surg nursing. It's no. It is amazing to get in a med-surg experience.
You're talking to the if you
We
want
both
to
did it.
if you want to skip through your ABCs of med surg, you're talking to the wrong nurses because Tony and I have had conversations before, like about like how we had plenty of people that went right into emergency or IC or whatever, but you don't have to start in med surg, but you're talking to 2 people that did. And we believe that it gives you a really good foundation.
But I will tell you, if you're interested in doing the trauma ICU specifically, and you're like, I love trauma and, maybe emergency nursing one day, our trauma step down unit at RMC does hire new grads. And it is an amazing place to start. It's a PCU level, so it is a little bit higher. There are some educational classes that are required of you directly after you're done with your main orientation that they do require a higher level of knowledge. So sometimes our new nurses struggle with those, but they are doable. You just have to study. You all know how to study at this point. So I highly recommend that floor. They also do our trauma ICU and trauma step down, also do all of our burns. So any crispy patients that come in are only allowed to go to trauma ICU or trauma step down. So it's a whole different education in that as well. And it is an amazing place to start. You do your 2 years there and you can move up to ICU, no problem. That wasn't my path, but I know the majority of the nurses in the ICU where I work did that path.
Awesome. Thank you for the insight.
Yeah, so
Absolutely.
it's not it's not 100% necessary. Cody, our president of cohort 16, I work with him at Health Central Hospital in Ocoee, and he precepted. He did his
Internship.
Yeah, he did his internship on the floor that I work on right now, intermediate critical care, right? So there's only one level that's higher acuity than us. So we get a lot of people that are teetering, right? So he did his internship there and then got hired right away and did really, really well. He was charge nurse in no time. Now he's on our most critical unit and whatnot. But I'll say this, you know how your nursing brain is being developed in school right now, like how you probably failed your first exam like miserably and you were like, God, no, like, and you had to learn how to, take your nursing exams. It's very similar to the real world nursing, like where you don't think critically, you think more task oriented. You're like, oh, got to get this patient's medication to them right now. Got to do the blood pressure because it's time for vitals right now. Like you're not keeping your head on a swivel and looking at everything as like a whole, or what could happen 3 steps down from this, or like maybe I need to look at this a little bit more carefully. It just your critical thinking isn't as developed, so it can be a little more forgiving on a med surg floor than when you've got patients that are really critically ill. You'll have more maybe like baby meltdowns, but anyway.
Baby meltdowns.
How long did you work in med surg before switching to trauma ICU?
So I have a little bit of a jagged path to the ICU. So I started on 10LP and I worked there for a year and a half. And my manager asked me to interview for an education position. And I didn't even apply for the position, but I was hired for it. And I worked in education for about 8 months. I missed bedside so much. Doing education in a hospital, you don't see patients. And it was a new experience for me. I don't regret doing it, but I definitely missed patient hands-on care. I miss interacting with patients and staff members because I did a lot of typing and collecting paperwork with a bunch of new nurses. And I love those new nurses and I still see them today and I still go check on them all the time. But then I transferred to our pool department, and I worked in pool for a year, but I started in pool. The Keely is the manager for the pool department, and she approached me about training up for PCU level nursing as soon as I entered into the pool. So I trained up for PCU, and then COVID hit, and I was approached again about training up for ICU. So I trained up for ICU in the pool department. I worked COVID ICU for a couple of months, and I had a conversation with Keely and said, I really want to take this opportunity. I was offered to move to trauma ICU, and she fully encouraged me to take it. So honestly, I would not be where I am right now if it weren't for COVID, and the fact that I was completely thrown into a critical care experience out of necessity. That's the honest truth. So.
And that's at ORMC, right?
Correct. Yeah. I work at ORMC, and I love the department I work for. Christy Hemingway is the manager for both the trauma ICU and trauma step down units. She's very reasonable. She is an amazing leader. So I've been very fortunate to have the managers and the experiences that I have within Orlando Health. I will 100%. Orlando Health is the way to go.
I signed up for that student internship there, but she, for some reason, registered me to sign up for the regular RN position at step down.
Wait, what?
Yeah, I signed up for the student nurse internship at trauma ICU, but she instead diverted my application to just apply for regular step down as a nurse.
So the student nurse positions, you will rotate through both floors.
Okay.
Yeah. So don't be surprised if they're like, hey, go to ICU today or whatever, because they will rotate you between trauma ICU and trauma step down.
And you guys can start thinking about this for your very last session when you do your preceptorship. You can make a request of where you'd like to be. I mean, what a great way to check out possible job, you know. A lot of people have job offers when they're done with that.
Absolutely.
You guys, one last question from me. Go ahead.
Trauma ICU does not hire new grads, but I know that neuro ICU does. And if you're thinking about doing our multi-system ICU, right now they are the COVID unit. So that's just something to think about when you're applying for jobs.
So where did
ladies, how many? Oh, I'm sorry. Go ahead. Go.
I was gonna say, where did you do your practicum? Is it practicum or preceptorship? I don't know. Practicum.
I did my practicum on ICC at ORMC. So our intermediate critical care unit at ORMC, and intermediate critical care at ORMC is like a gradient between ICU and our step down units. They do accept vents and patients with critical drips, but they have to be on minimal settings. So they're like the in between for our patients.
I was on that floor at ORMC. We got to like rotate for one day.
Yeah, it's a really good floor too to learn.
Ashley, what about you?
What?
Oh,
I did my I did my preceptorship at Health Central.
Okay.
And they hired her. She got a job right out of school.
Yeah, actually, everybody talked crap about Health Central. Everybody knows the little blah blah blah, like
Death Central.
Yeah, their little nickname or whatever. But I can tell you that I love that hospital, and it's been like a family to me. And everybody talked crap about me going there, and then a couple people were forced to go there because we just needed their positions, and they're all still there. And they were great nurses. Jenna Green and Cody are there, and a couple other people. But I did my preceptorship on SCU, Surgical Care Unit, and what's weird is one of our professors that what were they, like clinical professors that take you around, like Kelman and all those people. She actually worked on the unit that I did my preceptorship, and she was about to graduate with her NP. So when she left, I took her job. So I went right into the director, and I was like, I heard Daphne's leaving, or Professor Zador is leaving, and I said, I want her job because I want to work days. So I'll do it if you'll hire me. And so they did. And then I worked there for 2 years, charge nurse, and then now intermediate critical care. So.
How often do you two ladies use your mental health skills?
Mental health?
Every day.
Yeah.
Yeah, mental health. Remember that?
Yeah.
You use those skills you learn.
And you know, working trauma, I deal with people who are in situations they were never planning on being in. I deal with family members who are distraught. I deal with every walk of life you can imagine. You know, we have people that are just walking down the street and get shot in the head, or people who have mental illnesses and get shot in the head, or they're in their car and get shot in the head. Like, it doesn't matter. Everyone has trauma. You know, you don't get to just go through life without experiencing some type of, you know, detriment to your body. So we get to use mental health skills every single day. Same with Ashley's unit. They're the Wild West over there. So
yeah, and we get a lot of Baker Acts, a lot of oh my gosh, just anything and everything. I mean, all because they're in the hospital doesn't mean that they don't have coexisting mental health issues going on. And so we've got a lot of addiction. We've got a lot of mental health issues, a lot of Baker Acts. So you use it quite often.
And we use therapeutic communication with our doctors as well. Like, I deal with all of the baby doctors, all the residents, all the attendings, and they will regularly need encouragement just like we do. So therapeutic communication isn't just for your patients.
Yeah, and you can use it on family members too. Like, family members are a whole other, you know, group, because you don't just take care of a patient. You know, they usually have other people, you know, a crazy girlfriend or a, you know, kooky dad or whatever. Yeah. So you use it every single day. Yeah.
Yeah. Thank you, ladies.
Thank you.
You're
You all have
awesome.
a wonderful day.
Thank you.
Thank you.
Bye.
Thanks for
Thank
joining
you.
us. Love you. I owe you.
Love you.
dinner.
Miss you.
Thank you.
You leave
Guys,
by
it's 1
clicking.
o'clock.
Oh. There's something in the group
Bye.
chat.
Bye.
Yeah, check out the group chat. Guys, 15-minute break. Let's come back at 1:20, and we'll do a couple other things and wrap up our day. Okay?
Hey, Tony.
1:20. Yeah.
Hey, would you mind sharing your info? Like, would that be okay? Or...
Yeah, I will add it to the bottom like Ashley did.
Okay, I just have some, like, not personal questions, but just some questions on, like, ORMC and 10LP and stuff like that.
Gladly, I can answer any of those for you.
Okay, thank you so much. Thank you, Ashley. Appreciate it.